public again. No doubt. Mr. Mann, because you've asked quite a lot of questions, we've given you written answers, which will also be put into the minutes of the meeting, so they'll be available in public, and you'll have the opportunity again at the end of the meeting to ask any questions. But we thought, as there were so many, it'd be helpful to give you them in advance.
Yes, thank you.
Okay. So, in terms of the meeting itself, we've got apologies from Barbara Scott and Jackie Lawless. Jackie Lawless, Director of Finance, but Sam Allibone is representing Jackie today on all matters financial. Welcome. So, as usual, I just have to ask if there are anything to add to the register of declarations of interest, or are they up to date? I'll take silence as being they are up to date. And then we've got the meeting that was held in public on the 5th of April, the minutes of that meeting. Does anybody have any issue with the accuracy of those minutes? Okay, I'll take that as being that they are accepted. Then we've got the matters arising and action log, which I have momentarily displaced. You've got it handy. That's right. So we've got, first of all, recording of mandatory training to be reflected in the shared services agreement with OHR, and the response that this has been raised at the recent shared services meeting with HR, and it doesn't seem to be immediately possible using the HR systems available. So there is an update on that one. A Q4 update on the ROF has been done, and the report on waiting times is now an agenda item number 121. So unless anybody thinks otherwise, those are the matters arising and actions. So can I ask if anybody wants to notify any other business at the end of the meeting? No? Okay, thank you. So, governance developments. Andy, I think this is you I'm handing over to here, isn't it?
Thank you very much, Chair. So the assurance framework, which is provided in the pack, connects with papers that the board has seen over regular previous meetings and relates specifically to the strategic objectives for the current financial year. 2 months ago, the board looked at a development paper which anticipated the population of an assurance framework at this meeting, structured around 6 strategic risks, which are represented in this paper, though we have split number 1 into 1A and 1B. The paper connects with information about controls and assurance that are seen throughout the board pack in the Chief Executive Report, the Chair's escalation reports and the Integrated Performance Report, and provides an overarching framework at which various committees, which are designated as those with responsibility for scrutiny, can test and seek assurance as to the effectiveness of the controls over these strategic risks when they meet month by month. The reports will come from those committee chairs back to the board about the extent to which the committees are assured or not about the effectiveness of the controls and the availability of various assurances, and these provide a structure for those committees to work through during the year. On each of the 7 sheets which articulate an individual risk, there's a small trend graph in the top right-hand corner where we see the current score as of the mitigated risk remaining, with the target score, and we would expect to see during the year, hopefully with prudent control, the risk score will come down to within the board's planned appetite, and the documents themselves will get iterated throughout the year as the effectiveness of controls are brought to bear. There will be more assurance available about the controls. In some cases where it seems that risks are resistant to control, committees and the board may require executives to try to find additional controls to put in place, and we would anticipate an iteration every 1 to 2 months. The committees, when they meet, will see the individual risks that they are responsible for having scrutiny over, and the audit committee has a special role, which the audit committee discussed a couple of days ago. The audit committee has an overarching interest in seeing that this process and the assurances provided are fit for purpose and work, and the audit committee will report back to the board from that aspect, whilst the other committees will report back to the board about the specific risks for which they're responsible. I would like to thank the executive team for their engagement. This is not my work. I might have been a little bit of a choreographer for it, but the executives are the risk owners, and everybody has entered into it very actively and with enthusiasm, and I'm hoping the board will find that it meets the board's needs, and I'm sure all of us are willing to take questions.
Right, thank you. Any questions about this document? Okay, well, so Katie first and then Andy.
So my compliments to you firstly, Andy. I think it's a very comprehensive document. I have got one tiny criticism, and that is when you're putting the risks in the top left-hand corner, could you not put them on a green background? So I read them all, thought, oh, they're all right. And of course they're not necessarily. So if you could just change that, but I think it's very comprehensive, and thank you.
Okay, thank you. Andy?
Yeah, I agree. It's very comprehensive. The one thing that I was a little confused by. So one of the key risks is overwhelming demand, and that arises through the people committee.
Yeah, do apologise, everybody. This is a typo. On page 20 of the pack, I have failed to notice that I have written the identity of 3 committees incorrect. On the coloured sheets which follow, it is all correct. It's my mistake. Good spot and fair challenge.
Andy, can I just ask a question? I mean, perhaps I might direct this at Oliver. So on that risk around overwhelming demand, it says we have a low exposure to this risk. And insofar as overwhelming demand might mean unmet clinical need and waiting list building, does that risk exposure feel right?
I classified as overwhelming demand as overwhelming unplanned or non-elective demand. I guess there could be a definition where we can include overwhelming demand from an elective point of view. I can add that if people think it would be useful, because we do have some actions that we can put in around that in terms of the restoration recovery piece and the stuff that we're doing around access and the achievement of the RTT standards to act as the control about that.
I think it just feels a little bit too low for my liking. Bigger problem than that.
Andy, can I ask you a question about scoring? So if we look on the first page, it shows that, for example, competition for staff leading to critical shortages is one of the top risks. If we look on the second page, as risk number 3, it's got a current score of 25, which is the highest possible it can be. And then if we look on the relevant page that relates to this, down the right-hand column, it's all amber. Given that it's maximum red, should it not be red rather than amber in the right-hand column?
Yeah, I think that's a fair challenge. I have taken the approach when developing this paper for the board of trying to be proportionate in not trying to articulate every single control which is in place under each of the risks, and I started off with an aim to perhaps articulate about half a dozen. I don't know whether Anne would like to speak more to this item. I think that is a fair challenge, Chair, about the rating of each of the controls, though I feel that on an aggregate basis the overall risk probably does require the highest rating.
I think we also discussed the mitigations that are currently in play and how they might affect the risk. So I think that's why we went with an amber, because actually there is targeted recruitment for hard recruit roles. There is work ongoing with agency recruits and more difficult to recruit roles as well. So that was I think where we came with an amber rating, that we did have some mitigations in play.
So I think that would suggest then that on the second page, where you've got what's described as the current score as 25, you've actually have mitigated that to somewhat lower than 25.
The aim, for the avoidance of doubt, the aim is to give you the current score and for you to be able to see the trend during the year from where we started. So that the score which appears in the summary table on page 20 should be the current score.
Right.
So in other words, we've still got it at 25 in this document.
And that feels right to me, Chairman. We've got some very substantial gaps in our staffing.
I'm more inclined to agree with that than with the amber rating that appears in the subsequent page. But can I leave that one with you to think about before the next meeting? Okay. Sarah?
It was just to support that because I think the other school that's at 25 is at red.
Yeah.
So I think from a consistency basis, I think we should do that. But just to add my thanks, really, I think it's really helpful to see everything in one place and be able to read across all of the risks and see what's being done about them. So it's a really good document. Thank you.
Okay, thanks. So we basically say thank you to that, Randy, and it looks like a good format which we can continue to use for future meetings. Excellent. Okay, item 117. Well, apologies for not sending a written report, but I was away last week. So there's two things I just want to say. One is to clarify to Mr. Mann, who's asked why are we having two public meetings today. So this is the usual monthly public meeting that you have been to on previous occasions. The one later on this afternoon is the annual public meeting, so it's reporting on the whole year, not just the previous month. And the one that's later on this afternoon will be very different in nature to this one, so if you go to them both, you're not going to see much duplicated material. You'll see a report on the whole of the year. Plus, in between them, there's the opportunity to visit various parts of the organisation and participate in various activities. I will say this again when it comes to the annual public meeting, but this is normal behaviour in the UK, where you have the monthly meeting, but you also have an annual public meeting where you formally present your year's results and do other things to engage the public in the work of the organisation. So that's why there are two separate ones today. The other thing I just wanted to report on is we still only have 4 non-executive directors. The advert closes at the end of this week, I think. We currently have 8 applications, was the latest position. So we will be sorting out shortlisting and interviews in June, and hopefully we'll be able to fill that vacancy before too long. So those are the only 2 things that I wanted to report on. Okay, shall we move on to Teresa?
Thank you, Chair. So I'll invite you just to take the report largely as read. There are just a couple of things I would just like to draw to the board's attention. With regards to our planning and preparation for the TT event, which starts later on this week, the executive team have now considered and signed off a very comprehensive operational delivery plan and a communications plan associated with that. For this year, we have been able to strengthen our command structure arrangements, providing a bronze, silver and gold on call with an executive for the entire fortnight. We have managed to secure the additional staffing we identified as being needed. So I'm confident we go into this TT with a good level of planning and a written document which is now being socialised across all team with the relevant training taking place. I'm happy to take questions on that or invite the Director of Operations to make any further comments. Would also just like to confirm that the required outcomes framework for 22-23 has now been published ahead of it being laid before Tynwald in June. And for the purposes of our annual performance meeting later, an annual performance document has been produced which essentially just summarises our key achievements against our 3 strategic priorities for 21-22 of improving patient safety, creating a positive working culture and improving financial health. A full annual report will be produced later on in the year, but this is for the purposes of our annual public meeting later on today. And if I could just pick up on a couple of operational updates from the Horizon scan. Our business case review group and executive management committee has now approved 50% of the budget for increasing the ED staffing levels. This is part of that wider programme of improvement across the emergency departments. We had a very productive Cancer Services Performance Day involving the Cheshire and Mersey Cancer Alliance on the 29th of April, which was very well attended from across the organisation. We have linked in with the North West around a digital pathology solution for the organisation, and we have secured funding for a Macmillan matron in Cancer Services. Barbara Scott, who is our Director of Infrastructure, has indicated that she will be retiring at the end of June. We interviewed for replacement on the 13th of May, and we have made an offer of appointment, and that will be announced shortly. And I think we've continued to have discussions with Liverpool University Foundation Trust regarding our continued partnership working, which have been incredibly productive. My final point is that the care groups have undergone a performance and accountability review since the last meeting with the executive. We have focused on the internal governance and control arrangements, seeking assurance on those within the care groups. We brought the BMA cultural survey to the board last time, which we have accepted in full and are responding to in terms of both the executive-wide actions plus local actions for care groups to take forward, and we also considered the key achievements of the care groups and the key risks that have been identified during Q4. So very helpful set of performance and accountability reviews from the care groups. I'm happy to take any questions on the report.
Thank you. Don't seem to be any questions on your report. Okay, thank you. So let's move on then to the usual committee chairs reports, and in the order that we've got them here. So Andy, would you mind going first?
Mental health first. Sorry.
I'll just do it on the order it's on the agenda.
Yeah, sorry, just flicking over the agenda now. Oh, audit committee, sorry.
Yeah.
So the audit committee met only last Friday, so there's no written report here, unfortunately. So this was, we were largely spent quite a lot of time on the BAF, which the board has just seen now. Huge piece of work. It's starting to reflect the full scale of the challenges that we face. We met with internal audit at the same time to try and, we were actually due to discuss the annual audit plan, but the BAF effectively overturned some of that. It requires a rewrite. So members of the committee are going to meet, and internal audit are also going to look at the BAF, and together we're going to put together a plan which is focused entirely on the BAF to make sure we cover all potential gaps if possible. That's quite a big ask from a fairly limited resource from internal audit, but we will see whatever we can possibly cover. Right, that's it for that one.
Okay, well you'll get another turn in a bit.
I know.
So Katie, you're next, digital.
Thank you, Chair. So, yes, there's one item that we've already discussed actually informally amongst ourselves this morning, and that is about the Manx Care Record Advisory Board. It's felt that actually we could strengthen participation in that, and so that's an item that we need to make sure that we adhere to make sure that the Manx Care Record Advisory Board has better representation from us. So that was one thing. We had reports that there had been some demonstrations of potential software for Manx Care Records. That was very interesting. We also talked about clinical coding, the fact that we are up to date with clinical coding now, and the next stage is to start doing some quality checking of clinical coding to make sure that what was being done was of adequate standard. We talked about the fact that there were some staffing issues both on the integrated performance report side and the information governance side, and I'm pleased to report that staffing has been improved in those areas, or will about to be improved in those areas, which should actually ease some of the stresses that I think those teams are feeling. And so that's my report from the committee.
Again, I'm assuming that there's no questions, so move on to quality and safety. Sarah.
Thank you. So we had a meeting last week, I think. Yeah. And there's one issue to raise to the board, which is about compliance with antibiotic prescribing.
Unknown caller.
Sorry.
Mr. Chair.
I
Right.
understand that the Chief Executive and the Chair have sought additional input from other organisations about how this area is managed, and so we will be receiving a report back to the board about that issue. We made a decision that Manx Care would work with the DHSC and the Department of Public Health to undertake a review of COVID deaths. And then the other issues there are just for assurance, and the quality dashboard has developed very well, and we've got really good quality indicators and a really good report, a dashboard there to work with. We had an update on the Theatres Improvement Plan, which, as we know, is a really key piece of work for the organisation, and that's been going really well. 2 inspectors from the UK Health Security Agency visited the radiology department, and the audit was very positive, and in fact good practice was identified, and mortality reporting continues to need to be improved, and we look forward to receiving a further report on that in due course.
Thank you, Sarah.
Just a question, Chair. Sorry, Sarah, sorry I wasn't at that meeting, but I anticipated you would have had an opportunity to review the ENT report. Did you get a chance to review that?
We did, in detail, and now I can't remember what we said, Sri. We looked at the ENT report.
Yes, ENT report is currently at a stage of implementation plan, and we are waiting for the clinical lead and the ENT team to kind of come out with the timeframes, and then we
Yeah.
will present a comprehensive plan.
Yeah.
Of,
So we'll bring it back together when we've got the
Correct.
action plan as
Yes,
well as the
indeed.
report. Yeah.
So it goes through, the college report itself has got 10 themes on recommendations, and there are several actions to follow it. So it's a bit more comprehensive plan, so that we hope to get it for the next board meeting.
Thank you.
Okay, thanks. Okay, move on to finance, Nigel.
Thanks, Andrew. Yeah, so the Finance Performance and Commissioning Committee met on Friday last, and as you know, we've changed the format slightly of that meeting to make it longer, with more frequent breaks in order that we can get through the weighty and heavy agenda that we had. But we received some very comprehensive papers on the integrated performance report and performance management generally, and heard a sort of, I think, a very good explanation as to how we're approaching this. There's been a massive amount of work done in business information to standardise the extraction of our performance management statistics, and that was a very encouraging report indeed. We also received a very comprehensive paper on the so-called referral to treatment, and this is basically also known as the 18-week plan from referral to treatment. I've escalated that to the main board for discussion, because we do feel that we should not necessarily simply slavishly follow the UK model, although there are clearly some very important guidelines in that. And we do think that it will have a substantive financial effect on us in resourcing that. But clearly it is important, because it's one of our DHSC 22-23 mandate objectives, number 7 this year. So our stakeholders are expecting us to get on with this. So I have escalated that to the main board. The other elements we received very encouraging reports too on progress relating to commissioning and contracting generally, and how fast our team is coming up to speed on getting that back into compliance through adopting NHS framework agreements, and also there's a knock-on effect and lessons learned from the restoration and recovery plan as well in that area, which was, I think, very exciting and very positive results. Other than that, we also reviewed the March 22 management accounts, and there are the year-end management accounts, and of course rolled that on into April as well, which you haven't seen yet, but they are ready to they are ready for sight now. We did have sight of that at the committee, and that was no surprises. Thank you.
Thank you, Nigel. Okay, Sarah, next, people.
As the board will know, we asked to have a staff story at the People Committee, and we had a really positive staff story at the last People Committee. and it was really a delight to hear of someone's experience about moving jobs, about getting a lot of support from her line manager, but also, and it brings me to the point for escalation about clinical engagement. We are obviously trying to achieve a huge amount as a board in terms of change and development and cultural change, and the staff story touched on how she was moving from the community into Nobles and was concerned about that because she'd heard things about Nobles, and when she got to Nobles she was welcomed, she felt immediately part of the team, incredibly well supported, and she said she was now very keen to let people know that actually Nobles was a warm and welcoming place, and I think we need to build on that with some of the real challenges that we are faced with, not least from some of the survey results from the BMA report, which we are taking incredibly seriously as a board. We know that that now gives us a baseline for improvements, and I think as hard as it was as a read, it enables us to move forward and build developments and improvements. I won't go through the other items on the report because I think I don't have anything to add to them. But it was really fantastic to have that staff story, and I'd encourage any members of staff to come forward. We're a very welcoming committee.
Good. Finally then, Andy, the Mental Health Committee.
Thank you. So we met again last week. There are one or two key issues. So we were aware that delegations for the independent bodies that scrutinise Manx Care seemed to be not current. We picked that up with the board yesterday. So I think that's back under control, but that's current and that wasn't the case. The Associate Hospital Managers Panel, which is one of the key bodies because it scrutinises and makes sure that patients' rights are preserved, rights of freedom are preserved. They are currently under recruited and finding it quite hard to maintain the level of hearings required at the moment. There was partly a lack of clarity over who was responsible for managing and looking after them, if you like. But it became clear at the board to board again yesterday. It's finally clarified that actually this is Manx Care's responsibility, so we all need to take that on. But I do feel that actually MHAL may have not paid enough attention to that, which I apologise, Chair. I think that was probably my fault. Took my eye off the ball a bit with them, so I'm sorry about that. CQC preparations for mental health inspections are well advanced, and the team are everything seems to be being very well managed indeed. So I'm really interested to see the results of that. Finally, just a reminder that the Mental Health Committee is, as agreed by the board, will now change to an executive committee chaired by the medical director, and it will now, from this point forward, will report any recommendations or escalations through to the Quality and Safety Committee.
Thank you, Andy, and I think that is something that we decided on a few months ago and is now being completed.
Yes.
Okay. Right, so well, thank you to all the committee chairs, and interesting to see just how much work is done in those committees, and to hear that the Finance Committee is now 4 hours long makes it longer than the board. So anyway, thanks for all that. So priority number 1 is patient safety, integrated performance report. This is, well, Oliver and Sally, and maybe Paul too.
I was just going to take the report largely as read, because the narrative is pretty comprehensive. The only thing I wanted to just raise here, and the note was raised at the Finance, Performance and Commissioning Committee, was just the section around the legal challenge of the GP surgery around the achievement of the medication savings. I have spoken to our Chief Pharmaceutical Advisor this morning just to clarify that. I think the wording was slightly incorrect there, in that it's not a legal challenge, it's a query around the legalities of the data protection legislation and the application of that to this piece of work. So what's going to happen is our own data protection officer plus the chief pharmaceutical advisor is going to meet with the information commissioner just to clarify things, so that hopefully we can allay the GP practice's concerns around that piece of work progressing. And that was all I wanted to update you on.
Okay. Any questions for Oliver's part of the report, first of all? Yeah, Andy?
So on that particular issue, Oliver, if the ICO basically supports the position of the surgery, will that not impact, that will impact on cost savings, won't it? Our CIP targets are quite sensitive to some of this.
Yeah, obviously the CIP around primary care medications is quite comprehensive, and so we would need to consider the implications of that and how the ICO's decision or ruling would affect that implementation, but we'll take it as it comes.
Yeah, keep your fingers crossed.
Yeah.
That's fine. Okay, great, thanks.
Katie?
Thank you. Oliver, and I accept these two things don't necessarily tie up completely, but could you just comment on the fact that theatre hours are going up, so number of sessions performed are going up, but utilisation's going down? And I know they're not completely related, but they are slightly related, so could you just try and unpick that a bit, please?
Yes, so we have had some success over the past few months around anaesthetic recruitment, particularly around attracting some locums. So that has meant that we're able to increase the number of sessions offered. So that is the rise that you can see on the theatre sessions. The percentage utilisation has reduced because of the number of cancellations, both kind of planned cancellations and cancellations on the day due to our own bed pressures. Because we've had, particularly during March of this year, we had 2 wards that were dedicated to COVID, which meant that the remainder of the non-COVID volume of inpatients had to be accommodated on 2 less wards. That had an impact on our ability to accommodate our electives, and that meant that the number of cases that were going through the lists reduced. So although we had a benefit in terms of theatre staffing, we had a disbenefit in terms of our COVID pressures within the hospital. But I'm glad to report now that we have de-escalated our COVID inpatient arrangements, so all of the wards are now operating in the way that they should. So Ward 11 is currently the trauma ward, and Ward 12, which is normally the elective orthopaedic ward, is currently closed, but in the state a readiness to open for the TT.
Terrific. So just to, if I may just follow up on that, when do you then expect to hit your 85% target?
Well, I guess there's a couple of we still have quite a large amount of what we call medical outliers, so overspill from medicine into surgical beds. There was COVID related reasons for that, because many of our care homes were closed for admissions. Over the last 6 weeks, all of them have reopened, so there's now no impediment to discharging. But we still have, we have had quite a large number of what we call delayed transfers of care. So patients who have finished their medical treatment but have no plans to move on. What we have done over the last month is to spot purchase a number of beds within our care sector. So we've transferred around 20 patients from Nobles into care home, nursing home beds that we've paid for a period of 28 days to allow the plans for them to move on to their permanent placement to happen outside of the hospital. And that has had a really positive effect on our flow, our capacity of the hospital, and our ability to accommodate patients for elective surgery. So we have over the last month or so seen a very, very small number of cancellations due to bed pressures compared to previous months. So I'm hoping that we'll see a increase in that utilisation in April onwards.
Okay, you didn't directly answer the complete question. You didn't give me an actual answer to when you might hit 85%.
Ooh, I can't really.
I'm sure he might be able to help you.
Yeah. Sorry, you take it first.
No, no. Well, I would suggest it's multifactorial. Theatre efficiency is impacted by a number of factors. You know, the bed capacity issues are just part of that. I think we very much focused on theatre productivity and safety over the last year.
Indeed we did.
And I think we now start to move into a much more stronger focus around, you know, efficiency. And what I would suggest we take back from this board here is a piece of work which describes that in more detail with some form of trajectory about how we get to the 85%, and perhaps ask finance and performance to give that due scrutiny and bring it back to the board.
Yeah.
Three.
Just, sorry, Katie, can I just kind of answer a couple of things? First of all is that I think as a medical director looking after quality and safety, I think its first thing is to not completely translate theatre utilisation rates into being efficacy and productivity. I think there's a caution to be put in there. The second bit is with outsourcing or rather insourcing and outsourcing, and we got into a difficult kind of climate at the moment where complication rates, or rather surgeries that require longer operations, are now being utilised by the theatre itself. So there are different measures now that we need to take it. So I think it's just kind of bit of we are in a bit of a cusp at the moment. So I just urge you to kind of apply caution in trying to translate the theatre utilisation rates into productivity and efficiency. Yeah.
Okay, thank you.
Okay. Right, so I think that covers Oliver's part of it. Sally.
Yeah, and I need to apologise to the board that our narratives have not made it into this report, and that was a blip in us getting the data. And actually, the children's data is not even included in this report, and I'm not quite sure why that is. However, in terms of adult social care, I'll start with a good news story. Within one of the measures we have around our reablement service is that if people on discharge from hospital are engaged with the reablement service, that they are still at home 91 days later, and we've actually hit 100% this time. So we really need to understand that success so that we can continue with it. In adult learning disability respite beds, which normally are 100% occupied, it did go down to 88%, and that was a small period of time where we had to support somebody and their family in a crisis situation. So having them come into the respite unit, we had to reconfigure the numbers and staffing. The adult social work, you'll see, although we've managed to significantly improve the number of people getting a copy of their signed assessment, it went from 0% in January to 80% in February. We've seen a fall in March back down to 33%. That could be linked to, there's also been a downturn in the assessments being completed on time, down to 33%. And I'm pretty confident that was the impact of COVID and the transmission in the community and the staffing issues, which are coming back up now. Children's aren't in here. Children's data has remained pretty static. The only thing I would question is we've got a 0% in referral rate this month, which we normally are probably, we've always questioned it, it's been quite high at about 33%. So we're going to do a bit more understanding of that, and I think that's probably a mistake.
Any questions, Sally? Andy?
It's sort of a half question, half comment. I noticed that CAMS numbers percentage increase is pretty high. It's quite worrying that there's so many young people that seem to be seeking assistance with mental health issues, and just wondering whether we have the capacity with our partner as well, whether we can manage to cope with all of that.
It's not an area currently that I've got oversight of, but I think Teresa will come in, but you know, we are recognising that. We know what COVID, the impact that's had on children and young people, and that's why we're looking at developing things like the iThrive model of support around those young people.
Sorry, Sally, my question was misdirected. I apologise.
No, it's fine, and I think, you know, Sally has picked it up that, you know, I think every mental health service, whether that be children's and adolescents or adults, have seen a dramatic increase in referrals, partly as a result of COVID. We are looking to transfer some activity into the third sector partner. The Alison and the Restoration Recovery report talks about that. We very quickly need to identify further funding as part of the Restoration and Recovery Phase 3 to be able to continue that work. The move to the clinical model of the Thrive model is important because I think there is a lot of early help and support that we can provide, and resilience education work in schools, which starts to mitigate the risks both of children and adolescents who would ordinarily have been referred into the CAMS service to provide that early help and support. But we know from the work we have done to scrutinise the waiting list in CAMS, there are a lot of children in those services who can be dealt with adequately and well in other areas other than CAMS. So it is a part of the transformation programme that we're taking forward, and it's encouraging in the mandate that we will be developing a children and adolescent mental health strategy over the course of the next year. But we will need to look at investment plans as well for this service.
Thanks.
Okay, and Paul, did you want to?
Yes, please, Chairman. Like Sally, not all the measures on quality have made their way into the IPR, so I'm going to make reference, if I may, to the quality dashboard. We'll talk about some of the highlights that we've had in the last month in particular. We've got a very strong position on falls management. Overall, our falls volumes remain below the UK average, and our harmful falls in particular are very low, which is great news. Harm-free care scores are holding up despite the challenges that we have with staffing. The acquisition of pressure ulcers are starting to be reported on Datix, which is a real step forward for us. I have caveated with the board that we will expect the numbers to rise as we establish what our underlying baseline is, but I think this is a very positive step forward for us. Exposure to serious incidents is below the threshold that we set for the last year, and we have no overdue investigations on that log, which is great news for us. We've got an improving situation on safer surgery compliance, the WHO 5 checks, which is really brilliant progress on that. And in fact, we're probably on track to be compliant within the next 2 months, if not sooner. Strong evidence of mortality reviews taking place, and we've got full compliance with duty of candour. And importantly, we've done well with our blood culture contamination rate. Particularly in April, we managed to reduce that much further down. There are some areas that we're flagging for improvement, and they are in relation to VTE assessment, which is a medical assessment done within 12 hours of admission to assess your risk of blood clots and then the right intervention that's needed. We've seen a deterioration in that, which is something that we're working on at the moment. The senior medical review of antibiotic prescriptions within 2 to 3 days of the treatment commencing. We saw a deterioration in that, and I've previously escalated that to the board. We're going to take some action on that, and we'll be able to report in due course. We want to make some progress on something called the Malnutrition Universal Screening Tool, which we refer to as MUST. This assessment we make just to ensure everybody's properly hydrated and gets the right level of nutrition. I want to see some improvement on that as we go forward in the next year. And whilst we've made some progress with complaints, the process and the standard, we've slipped in the last few months in particular on the timeliness of response when it's compared against the 20-day threshold. Now that threshold is open to interpretation within the complaints regulations. We're looking at that at the moment with IRB and others just to make sure that we can recalibrate that measure so that it is more meaningful to everybody. And we've still got some work to do with mandatory training. The third element that I want to raise as an issue is in relation to CAS alerts, and these are safety alerts that are issued to healthcare providers, and the expectation is that they're acted upon and dealt with. And we have some work to do to increase our responsiveness to those areas, and on all those fronts, Chairman, I'm taking steps to address them.
Just for my benefit, one of those points you made, the 20-day standard for complaints, you said is open to interpretation. What about it? Is it whether it's working days or?
No, it's whether that you have to. It's a little bit technical, but you have to respond within 20 days. We respond at a very high percentage within 2 days, but the complaint is not necessarily concluded within 20 days. And to be fair, if you really want to do a proper, thorough thoughtful response to a complaint, you
Yeah.
probably won't get it done within 20 days. You need to give it a lot of work.
Yeah.
That's what we mean by that. And
understand.
the new regulations have been really helpful, I think, in clarifying how we can make that more meaningful
So
for people.
I guess we would always acknowledge complaints pretty much straight away,
And we do.
which is a response.
Yeah.
But then a proper investigation and response can often be 20 days if it's straightforward,
It
but
can.
equally, okay, I understand, thank you.
Yes, yeah.
Yeah, Andy?
So I take it really what you're saying is you'll use more of the holding responses at the 20-day stage. That we're very sorry, this is a complicated issue. We can't do it in this, and we
Yes.
forecast.
And to build on that, Andrew, take the opportunity to negotiate with the person who's making the complaint what might be a reasonable and realistic time frame to deal with the issue, depending on how complex it is.
They can be hugely complex, can't they?
So that's quarterly, Chairman. Thank you.
Okay, sweet.
Just on that, just to add to what Paul said, it's just not about looking at the complaints, and we need to triangulate between the complaints, the incidents, and the litigations that come with it. So we have got a good kind of amount of thematic issues coming out of it, and so hopefully in the coming months, Paul along with me will be able to present to you, or present to the board as it was, about the issues that actually bother the current organisation itself, and it will have a bit more insight into how the patients are being managed.
Yeah, I mean, I think that is pretty common standard to have maybe a quarterly report. So you've got the monthly report on the main headline, but maybe a quarterly report on trends and identifying where there's similarity of themes.
And we would normally take that through the QSC, I think, in the first instance, and allow a proper scrutiny in that environment, and then a summary, perhaps, for the board.
Sure, no, that'd be good. Okay, anything else on the IPR? Right, Oliver, back to you on restoration and recovery.
So a bit of background. So we've received or secured about £2.8 million so far since the launch of Manx Care to help fund our restoration and recovery activities. These have been used across a number of specialties, including ophthalmology, endoscopy, orthopaedics, and 7 outpatient specialties, which includes cardiology, respiratory, gastroenterology, and pain management. So far with our money, we've managed to achieve or deliver an additional 458 endoscopy procedures, 264 cataract operations, 49 hip and knee replacements, and 168 patients are now on a virtual outpatient pathway. But of the funding that we've secured, we've still got 87 cataract procedures to deliver, 51 hip and knee replacements. We've still got 2,950 virtual outpatient pathways to offer, and also 131 patients to commence their trauma therapy pathway, which is a project or a piece of work that's being delivered by Minds Matter, which is a third sector organisation based on the island. I just wanted to pay tribute particularly the partnership between Synaptic, which is our private sector provider, who is providing a number of staff on site here at Nobles to support particularly the cataract and the orthopaedic activity. But the orthopaedic activity is a joint venture between Synaptic and our own staff. Predominantly our orthopaedic surgeons, which is at all tiers of consultants and the associate specialist, but also quite a number of our own orthopaedic specialist theatre staff. Between Synaptic and our own staff, we've managed to achieve quite a number of developments or improvements in the pathway. So from an orthopaedic point of view, the surgeons have actually been able to increase the productivity on their lists. So whereas previously they would do 3 patients on a list, and they can now do 4. And also we've managed to reduce significantly the length of stay of patients who have undergone a hip or knee procedure. So whereas previously the length of stay was between 2 or 3 days on the ward after their hip or knee replacement, Of the 49 patients that we've operated on, 33 patients have been able to go home the next day, which is quite a significant achievement, and actually a length of stay that is the envy of most hospitals in the UK, and that's thanks to the partnership working, the really good partnership working between Synaptic and our own consultants.
So can I, just on that very last point, Oliver, have we been monitoring readmissions as well?
We have. I don't have that data, but I believe that they are extremely low, if not zero, but I'd be able to feedback that.
I mean, it is extraordinarily high percentage of people going home within one day, which is in my orthopaedic experience most unusual. But anyway, well done. That's great. Can I ask a more general question? And I'm a stuck record here. I keep wanting to know about waiting times. How long do you have to wait now for orthopaedics, for ophthalmology, and so on? And the report doesn't give that. You gave a report in January to Tynwald when you said, here's the waiting times now. Here's what we're going to do, and here's what the waiting times will be at the end of this year. Can you, off the top of your head, can you say whether, first of all, we're on track with that?
We are on track with it. We do have the, particularly for orthopaedics and cataracts, despite the significant reduction in our, or the large number of procedures that we've commissioned through Synaptic, we still have a large waiting list remaining. We have just submitted through the DHSC a business case to eliminate the rest of that waiting list, and that is tracking. That has a completion date for the end of the year, which is what we committed to. That piece of that document is currently going through the DHSC and onwards through to the government for consideration, and we're hopeful that that will be supported.
Okay, final question for me, same issue. As you know, I've been doing a tour of GP premises, or GP practices I should say. One of the common themes that I was told was that although they get given a monthly waiting time measure, they don't believe it.
No. It is, we do know that there is significant data quality issues within both the outpatient and the inpatient waiting list, so that we know that there are people on there who may no longer require the operation, who may have moved off the island, etc. So there's a huge piece of data validation that's going on within our patient information centre to clear all of that up. So we've actually appointed a temporary validation team, and we'll be looking to make that permanent at some point as part of the case that surrounds the implementation of the access policy. We have just appointed a elective access manager to work within the performance team to actually lead the implementation of that long term, because we know that data validation is not something that is a one-off job. It's something that we need to keep on top of all the time, and once we are in a position where we are happy that that data, both the outpatient and the inpatient waiting list data, is correct, we would want to start publishing that publicly on our own website, so not just for GPs to provide, but for people to actually be able to access that information.
And how far off that are we?
We're probably about 3 months away from doing that full data validation piece. There's a huge amount that we inherited quite a significant challenge from that point of view, and it's taking a lot of resource to, because there is tens of thousands of people that need to be validated off.
I mean, part of the reason behind all my questions about this is I believe that we're actually doing a huge amount better than the UK, but I haven't got the evidence to show that. So in 3 months' time we will have that. Okay, thanks. Sorry, I've been monopolising questions. Anybody else want to?
Andrew, if I may.
Yes,
Oliver, I too am worried about the sort of one-day discharge, but could you assure me, because costs, let's get the costs down, and what slightly worries me is that we're allowing patients to leave hospital after a day. That is clinically led, I presume? Yeah.
Oh yeah, so the discharge decision comes from the consultant. It's an MDT decision really between the consultant principally the physiotherapist, because it's the physiotherapist that is able to assess whether someone can mobilise enough to be able to be safe to discharge, and so that is always a clinically led decision. And as I say, 33 out of the 49 patients went home on the day after, but there was still another 16 that were assessed as not being able to, so stayed in a little bit longer.
Thank you very much.
Yes, sir.
I think it is a way of progressing. It's an ambition that you go home the next day. I went home the next day after my knee operation, and I think so long as you are able to perform certain tasks, you are allowed to leave the building. And then obviously it is a commitment to physio, which is much better delivered outside hospitals. Yes.
Okay, any more questions for Oliver? No? Right, so Anne, workforce and culture update.
Yep, I just want to update on a few projects that the board have been cited on. So the vacancies now seem to be reaching a steady state in terms of the information we're getting back as we feed out reports to divisions. It is running around 20%, which I think, as we all know, represents some significant challenges to us. With regard to mandatory training, we now have a draft mandatory training policy, which I've shared with Paul and hope to share more widely within the next week or so. And that's based on the UK full-time mandatory training policy. So hopefully we'll be able to adopt that. Just a quick update on the action points around what's available from eLearn Man, and I have shared with Oliver and Paul a dashboard which is available at team level. I need to do a bit more work to find out whether that can be the similar dashboard can be available at a sort of macro level, organisational level. But I think that's quite, even if felt like it's quite a useful document that we've seen. Just on the workforce and culture team, they have prepared a presentation on a look back in the past year and what's happened in the next year. That's been shared in a number of forums, but it's yet to be shared with more widely with some of the management teams. But essentially, if I could describe the first year as being laying the foundations and doing some research, listening to our staff, a lot of stakeholder involvement, and some of the specific work areas. So looking forward, they are going to analyse the data that were available in our HR metrics much more closely and start triangulating that to identify where the priorities need to be going forward. Again, more engagement, we're looking at appraisal, reward and recognition systems, and they're reporting into the project management department monthly about where those priorities will be. And I think the other thing I've discussed with some of you is around making sure the activity of all the HR and all the teams are aligned and we're not letting things drop between the cracks and are reporting the right things.
Thank you. Can't see any hands up. So, well done.
It's not so much a question, but clearly I think there is a need to refocus, reconsider the priorities around culture, particularly workforce and culture, along with the workforce and culture team and transformation with OHR and the work we've got running internally through a number of different strands. So we have got our plan for 22-23 largely signed off. It is reflected in the required outcomes framework, but I think we would like the opportunity to just make sure we are focusing on the right things given some of the feedback we've had, some of the things that have come through the BAF. I think it's pertinent we take that time just to make sure that we have got the right priorities identified and we're putting the right focus. So we've agreed to do that as an executive initially, but then perhaps bringing it back through the people committee for some scrutiny.
Yeah, that would be welcome.
Sure. Right, well, we'll move on to the next item then, which is the finance report. So, Sam?
Yeah, there's two reports been circulated. The year-end result, which I think it was within the supplementary vote that was approved. So unless there's any specific questions on March, I'll just move on to April.
Yes, please,
Okay.
please do. I think we've been through March quite a few times, so you're welcome to move into April.
Okay, it's just to say that the April result was on budget, but this isn't really the expected trend at the moment, and we would expect costs to increase over the course of the year. This is partly being driven by tertiary activity and employee costs. So an initial forecast has been prepared, but this is just to highlight the financial risks at the moment. And if they're sort of highlighted early, the expectation is that these can be managed. But further work will need to be undertaken with the DHSC about how the gap can be addressed, and then any forecasting going forward can be updated with any of these actions.
Okay, thank you. The increase in tertiary activity, why do we think that is happening?
I don't think it's so much increasing, it's that we're expecting it to be the same as 21-22, and some of that activity was recovered last year. So at the moment the expectation is that activity will remain the same.
Right, so that last year was a depressed year because of COVID and it's expected to return to the level before.
Yeah.
I understand. Okay, any more questions for our Jackie representative here? No. Right, okay. We must be getting slicker at this. We've gone through the business quite quickly there. So, in that case, nobody wanted to bring up any other business. So it's time for any questions from the public.
Well, Mr. Chairman, you've given me the answers to the questions I put, but I can't say that I'm happy in respect of the answer that comes as far as the GP facilities in the north of the island are concerned. I will address that again between now and the next meeting. I always said I would give credit where credit is due, and I can at least give credit today for one thing, which is the walk-in chest X-ray service at Nobles Hospital, from which I can report that it's an excellent service. I attended it myself and went through the entire procedure in under 15 minutes. And the more important aspect is that the connectivity between the reporting and the GP surgery is now working, in that the full report came through on the patient access. And that is a massive improvement from where we were a year ago. So I did say I'd give credit when it's due. That's the first time I'm giving credit where it's due. In respect of your answers as far as the GP surgery in the north of the island is concerned, we've got a long, long way to go there. If that's an acceptable answer for the people of the north of the island, Mr. Chairman, it's a long way far adrift. I could ask this board to look seriously at the situation in the north of the island. It needs serious looking at and some immediate attention. But beyond that, I have no further questions, Mr. Chairman.
Okay, well, fair enough, and thank you for giving us credit where credit's due. I think the issue, and I have personally been around all of the GP practices on the island now, and there is need everywhere.
It's grim, Mr. Chairman, across the whole island.
Well, not totally grim. There are some quite...
No, it is grim, Mr. Chairman, and if you have only to step outside here and speak to the general public about it, it is pretty grim.
Well, we can disagree. I agree that there are some premises which are in urgent need of investment, and there are some premises which are too small for the number of patients they serve. But I don't think there's a particularly worse case in the north than anywhere else. I think possibly the east is where there is the greatest shortage. But that's what the answer to your question says, is that there is analysis of need across the island, which will then be used to prioritise the money available.
But it's absolutely everything, Mr. Chairman. It's not just premises.
Sure.
It's what's in the premises.
Sure.
And it's a culture, it's an attitude from the moment you ring through to the doctor's surgery. Now, whether they're under excessive pressure, and I'm sure they are, but there's basic training that's missing with some of them.
Well, I guess I have to ask Oliver to comment as you see fit on that.
I mean, can you expand on that in terms of the basic training? Is there specific training you think is lacking?
Well, the first thing I would say is that in my experience of ringing, I've now had experience of the GP surgery in the north of the island and the one in Laxey and Onken.
Right.
There's a tendency for staff, when you ring in, to try and give medical advice. That is, whether they're intending to or not, you end up effectively bouncing your condition off of the receptionist or whoever's answering the telephone. Now, that on a very basic thing for any organisation, surely that those staff are or should be instructed to say we're not trained to give medical advice. But it's running actually in various areas of the organisation. And we've now moved from the stage where the GPs suddenly found themselves able to use a telephone consultation. Now if you write to your doctor or you make a phone call into your doctor, the response we're now getting is, oh, you'll get your call back, but it's now treated as another telephone consultation. So to give you an example, just today, we simply sought a return phone call from a GP, and the nearest return phone call we could be given wasn't the same day, wasn't perhaps tomorrow, the 15th of June. Now that, I can't think of any other organisation that would get away with doing that. So there's been a shift from a person-to-person consultation with your doctor through to the COVID situation where you contacted your doctor through the telephone, and now where those telephones, your general thing now is being converted, an ordinary phone call is now being converted into a consultation, and you can now wait out a fortnight. So there's your basic example. You're asking for what the man in the street receives from his GP these days, and I can tell you that that is an experience right across the island. If you try and obtain any kind of decent contact with your GP surgeons. Now I can say that if you have an urgency and you're lucky enough to get through at 8:30 in the morning, you will get an appointment. But if you're unlucky and for some reason you don't, by 9 o'clock, you're going to struggle to get a same-day appointment, however urgent the situation is. And those patients are turning up on the door of accident and emergency. And that's where your accident and emergency thing is coming under unnecessary pressure, simply because the GP situation across the island is completely disorganised. And I'm sorry, but the GPs are running the roost at the expense of the general public, and that's the area that needs the concentration.
Okay. Well, thank you very much for those comments. I think it's really important actually that we hear what, as you say, the person in the street has to say, and I think it's important that we get a sort of a continuous process of feedback from what's going on and what people are thinking. So thank you very much for bringing that, and certainly I regularly speak to all of the GPs, and I will raise those. I can't necessarily give you a personal answer back. I think you've mentioned some specific cases that may be specific to you, but in terms of the general principles of what you're talking about, I will certainly raise those with the GPs, and as a kind of what the person in the street is talking about. So that's really valuable. Thank you very much.
Could I just indicate 2 areas where improvement could be made?
Okay.
One is to introduce a triage on the end of the telephone.
Right.
So you come through your receptionist. Every patient is triaged in much the same way as if you walk into accident and emergency.
Yeah.
And then these doctor surgeries need to abandon the appointment system. It sounds a crazy thing to do, but in fact, once your patients have been triaged and they then arrive, rather like they do at the blood clinic with the cheese counter number, and they sit there in order, a sick patient will wait to be seen. A patient who's not that sick won't wait. He'll go home.
Okay.
And I can assure you that system, it does work in other parts of the world, and speaking from experience, it did work on the Isle of Man years ago.
Well,
You'll find you get a much rapid throughput of patients during the day.
I mean, certainly, I mean, I can't promise that that's what we would implement, but I mean, certainly innovation in terms of how appointments are delivered is absolutely something that all GP surgeries are looking into. So exactly what that will look like in the future, I can't be 100% sure. Each GP surgery is obviously a separate business, and greatly they kind of arrange their appointments as is suitable for the local needs of their local area. But I mean, absolutely, I completely agree with you that we need innovation in how appointments are arranged. But I will absolutely feed that back as well to all the GPs. So thank you very much.
Okay, thank you. Well, that concludes the questions from the public, and it concludes the meeting. So, thanks everybody. And as I said before, that we've now got the annual event, which you're very welcome to. And the next public meeting is on the 20-something of July.
It's written on the bottom.
I know it is.
It's not written on the bottom of the agenda.
The next meeting is in July.
Tuesday the 6th.
Tuesday the 6th, sorry.